Okay, we've reached Unit 11. Today we're going to talk about the specific drug classes, kind of their mode of action, whether they're bactericidal or bacteriostatic, all the little things that we need to know about the different antibiotic classes. Here we go, Unit 11. So antibiotics have been around for quite a while, about 80 to 90 years, and there's about 4 to 6 new antibiotics introduced every year. There are about 400 antimicrobials available in 18 classes, and we're going to talk about several of those classes. Penicillin was first discovered by Alexander Fleming in 1928, but it was not used in practical application until 1939. It was actually first used to treat a gonorrhea infection in the eyes of a baby. This was a very unrefined penicillin drug at the very beginning back in the 1930s. Susceptibility testing can aid in the treatment of infectious diseases and can also be used to help identify microbes. For example, we can identify certain microbes based on their antibiogram, and an antibiogram is basically the susceptibility fingerprint of an organism. So for example, we could identify Stenotrophomonas multifida by looking at its antibiogram because we can tell that that organism is very, very resistant to most antibiotics. With susceptibility information, we are better able to control the spread of infections like never before. Bum, bum, bum. So different organisms show different susceptibility patterns, and those susceptibility patterns can be from very sensitive up until very, very resistant. And like I mentioned, an antibiogram is the susceptibility pattern of any given organism when it comes to if they are susceptible or resistant to an antibiotic. I call this the fingerprint of the organism. Now, certain therapeutic drugs have to be monitored. We can't just hand out antibiotics to every person that has an infection and then just walk away. Some situations need to be monitored because there can be a narrow window between toxic and therapeutic levels, so we could actually develop some sort of nephrotoxicity or hepatotoxicity in our patient. We want to avoid that. We want to make sure that our patients don't develop a dose-dependent depression of hematopoiesis. In other words, we want to make sure they don't develop poor development of their red blood cells. When we're given our patients large doses of antibiotics that have to be used, we want to avoid toxic effects on their organs. We also have to monitor drugs in certain life-threatening situations, and when patients are on oral therapy, we need to make sure that the drug is being absorbed correctly or adequately. So here I want to talk about the rules of host defenses, which basically means how humans respond to an infection. Okay? The hosts that are immunologically normal often recover, but this is dependent on the patient's age and immune status. And they can recover without antibiotic treatment because of their T cells and B cells. They can make antibodies, etc. We have to look at their immune status. And then drug levels in individual patients' sera can be variable. So it might be concentrated at one level in one patient and be concentrated in the serum of another patient at a different level. There are several factors that contribute to antibiotic levels in the blood. Some things that can actually contribute to that would be the blood instability of one recipient versus another. This is called the hemodynamics of your patient, how blood essentially circulates within the body. We have to consider the age of the patient. Is the patient very young or very old? But that will actually determine how much antibiotic gets into their blood. We also have to look at their body composition. If you have a patient that has lean mass versus adipose tissue, this affects drug absorption. And then if the patient has any underlying maladies, such as an underlying disease, this can actually affect how much antibiotic gets into the blood. Patients who are monitored must have their blood samples collected and tested periodically to see if adequate levels of the drug are being administered to the patient. Peak and trough levels are monitored on all kinds of drugs, not just antibiotics. For example, you can see peak and trough levels being measured in drugs like acetaminophen or Dilantin. Peak drug levels are collected 30 minutes after the drug is given, and trough drug levels are collected just before the next dose is administered. So sometimes when we are giving antibiotics, we have to look at peak and trough levels in their serum. Whenever we're treating a patient with an antibiotic, we want to make sure that we're getting the correct concentration of the drug into their serum while causing the least amount of toxicity to the patient. We do want to avoid things that are nephrotoxic or hepatotoxic. Adequate drug levels alone do not guarantee a cure, and there are other factors that are also involved. For instance, we want to make sure that our patient isn't allergic to the certain drug that's being prescribed. One such drug that people are highly allergic to is penicillin. We also want to consider the toxicity of the drug, liver and renal function. We want to consider that. We want to make sure our patient has no genetic abnormalities. We want to make sure our patient isn't pregnant, and if they are, we want to evaluate how well we can get that antibiotic into their serum. And then also we want to consider the site of infection. Can our antibiotic cross the blood-brain barrier? So then we have to interpret our susceptibility tests. So we might be given some numbers or Kirby-Bauer or microdilution susceptibility. We have to actually interpret whether our infection is either susceptible, intermediate, or resistant to these drugs. And most microbiology labs use what's known as a time-kill curve as a way of interpreting susceptibility tests. This is a method to determine the rate of bacterial killing. It's a method of time and concentration. Antibiotics are tested at different concentrations and different time intervals to determine which concentration of drug is going to inhibit that organism in the quickest amount of time. Whenever we're treating a patient with antibiotics, we do want to avoid antagonism of certain drugs. We want to make sure that if we're using a drug combination that they are actually synergistic to one another and not antagonistic to one another. And we can do that by gathering MICs, MBCs, and rate and time of killing and suppression of the infectious organism. So one such way that we can test antibiotic susceptibility or resistance is by setting up a Kirby-Bauer disc diffusion plate. And we have to make sure that we are reading those plates out appropriately. We want to make sure that growth has occurred all over the plate, and then when you set that plate up with a swab, that there are no gaps in between the lines of organism. You shouldn't have any isolated colonies. We're actually making a lawn in this test method. We want to make sure that we measure all of our zone sizes in millimeters, and we want to measure the zone diameter on all different antimicrobials. If you have any Proteus that you're looking at, if you're doing a susceptibility test against Proteus, we want to make sure that we ignore the swarming of Proteus. And if there's any slight growth around sulfa drugs, we want to ignore that as well. Now, if you have zones of inhibition where there are organisms growing inside of that zone, those are considered mutants, and we would actually consider that drug resistant. So in this picture, you can see they've done the Kirby-Bauer disc diffusion test, and they are measuring the zone of inhibition with calipers. And in this particular case, it appears as though that the organism is sensitive to that particular antibiotic, although we would have to compare that to our package insert. There are actually many factors that can affect the way the Kirby-Bauer zone sizes present. These kinds of errors can lead to a delay in patient treatment and can even cause further detriment to our patient. Kirby-Bauer disc diffusion susceptibility tests must be performed correctly each and every time, and I'm going to talk about things in the upcoming slides that can cause false decreased zones and also false increased zone sizes. So let's go ahead here and talk about things that can cause a decreased zone size. This makes the organism appear more resistant. So here we have some errors that can occur that makes our zone size actually smaller than is actually the case. So a small zone would make the antibiotic appear to be more resistant because the organism creeps up near the antibiotic. If you have the improper storage of discs, that can actually decrease your zone size. These discs should be frozen until we're ready to use our working discs, and those would be refrigerated with the desiccant. If you have your inoculum too heavy, that can make your bug appear to be more resistant. We want to make sure that we always have a 0.5 McFarland standard before inoculating our Mueller-Hinton plate. If there's too much moisture on the plate, this can cause our zone size to appear smaller and more resistant. If you drop the disc onto one location, you should not move that disc at all once it's dropped because the drug has already started to diffuse and is lost forever. If you incubate the plate at the wrong atmosphere or incubate it for too long, greater than 20 hours, you can get falsely decreased zone sizes. So these are all things that make the organism appear to be more resistant to certain antibiotics. There are also technical things that we can do that would increase the zone size, making our organism appear to be more sensitive. So here we would have a zone size that is larger than what we would expect, and the larger zone size makes the antibiotic appear to be more sensitive. Okay, if you use a media other than Mueller-Hinton, this can make your zone size appear to be larger than it's actually supposed to be. These medias actually lack the nutrition required for the Kirby-Bauer test. Plates should be incubated at 35 degrees. They should not be incubated lower or higher than 35 degrees Celsius. This could make your bug appear to be more sensitive to certain drug types. If you use less than the required volume of agar in the plate, that's usually not a problem because we buy commercially made plates, but if you were making your own agar plates, this could be an issue. If you used an inoculum that was lighter than a 0.5 McFarland standard, that's going to make your bug appear to be more sensitive to certain drugs. So these are all things that you want to avoid because you don't want your bug to appear more sensitive to certain drugs. Now, whenever we do the Kirby-Bauer disc diffusion test, we want to interpret our zone sizes as either susceptible, intermediate, or resistant. So if you have an infection that may be expected to respond to our usual low doses of the drug, then it is considered susceptible to that drug. If you have an organism that responds to doses higher than usually prescribed, we could say that our bug is actually intermediate to that drug. And then if you have an organism that does not respond to even high doses of the drug, we would say that our bug is resistant to that drug. And we report that out as S, I, or R, sensitive, intermediate, or resistant. And that's all the doctor would see. And they're going to give the antibiotic that is the most sensitive. In the microdilution test, we're going to use microscan in our laboratory. We have microtiter wells that are coated with different concentrations of antibiotics. The antibiotics are listed on the plates along with their concentrations, and they're usually in some sort of grouping on the plate. And that grouping can be either horizontal, vertical. That's how you're going to see the antibiotics placed on the 96 well plate. Following incubation, the appearance of a button of growth at the bottom of the well indicates that your bug is growing in the presence of that concentration of antibiotic, so it would be resistant to that antibiotic. Microscan plates can be read manually, or you can put it on an instrument that incorporates a fluorescence detection system for susceptibility testing in the microtiter wells. Let me show you a picture of what this looks like. So here's an example of an organism on a 96 well microscan plate, and you can see that we have serial dilutions or concentrations of certain antibiotics. If your bug grows in the presence of that antibiotic, it means that it's resistant to that particular antibiotic. So if you look at the example at the very bottom, we have ceftazidime. We have 1 microgram, 2 micrograms, 4 micrograms, and 8 micrograms of ceftazidime. If E. coli grows in the presence of 1 microgram and 2 micrograms, the MIC would actually be 4. It's the first well that does not grow. That is our that is our minimal inhibitory concentration. So the MIC for this particular example would be 4 micrograms of ceftazidime. That's the dose that we want to use for our patient. The E-test or epsilometer test is known as an exponential gradient testing method. It is similar. It has a similar setup as the Kirby-Bauer, where we use a 0.5 McFarland standard. We make a lawn. The antimicrobial agent or the antibiotic is actually impregnated on a strip, and that strip is placed on our agar after we've made a lawn of our bug. The MIC is determined at where the sharp end of the zone meets the strip, and you can see that in the image there on the right. In this particular image, we can say our MIC is 0.75 milligrams per liter, okay? Often used for fastidious organisms like Streptococcus pneumoniae or Haemophilus influenza. That is the E-test. There are certain organisms that always need to be tested for beta-lactamase production. Those organisms would be Staphylococcus aureus, Enterococcus, Neisseria gonorrhea, and even Haemophilus influenza. We want to make sure that our bug is either sensitive to the ampicillin, penicillin, and first-generation cephalosporins, or we want to make sure they're resistant. If they are resistant, then we cannot use penicillin, ampicillin, or first-generation cephalosporins. Okay, this is sometimes referred to as the cephinase procedure, probably because the organisms are beta-lactamase positive. They are also resistant to our first-generation cephalosporins. Okay, organisms that are resistant or make the beta-lactamase enzyme will actually mess up the beta-lactam ring of these types of drugs. ESBLs are extended spectrum beta-lactamase producers, and sometimes you can see this in E. coli and also Klebsiella species. Our usual strains that are resistant to beta-lactam drugs are also resistant to our third-generation cephalosporins. You can do this test by making a lawn of your organism on a Mueller-Hinton agar and then dropping a couple discs. In the example on the right, we've dropped a ceftazidime disc and then a ceftazidime disc with clavulanic acid. And if you look at the zone size for clavulanic acid and ceftazidime, you can see that it's greater than 5 millimeters larger than the ceftazidime disc alone, and that means that we are dealing with an extended spectrum beta-lactamase producer. Again, these organisms are resistant to our penicillins, ampicillins, and also our fourth generation and third generation cephalosporins. Now, anytime we use antimicrobials, we want to avoid toxic effects in our patients. And as you can see here with the different classes of antibiotics, there are some toxic reactions that are associated with these classes of antibiotics. For example, people tend to have allergic reactions to penicillin, cephalosporins, and your sulfonamides. They can have bone marrow depression when it comes to the sulfonamides. They can have brain toxicity or neurotoxicity with penicillin. They can have kidney toxicity or nephrotoxicity when being exposed to cephalosporins, sulfonamides, or the aminoglycosides. And then they can have liver toxicity or hepatotoxicity when it comes to the cephalosporins. And then they can also develop pseudomembranous colitis or tummy troubles when they are exposed to cephalosporins or the aminoglycosides. So let's go ahead and break down the different classes of antibiotics. For your exam, you'll need to know which antibiotic is bacteriostatic or bactericidal. You'll need to know the mode of action or how the antibiotic works. Give me one example of the drug in each category, and that's the generic name. You don't need to give me the trade name. And then one example of an organism that is effective by that certain drug. Okay? The beta-lactams are your penicillins. They are bactericidal, so they are meant to kill all existing organism, and they do that by inhibiting cell wall synthesis. The penicillins are used to treat things like staphylococcus infections, Neisseria gonorrhea, streptococcus group A, and non-enteric gram-negative rods. Keep in mind that about 15% of the population is allergic to penicillin drugs. Now, you don't need to know all of these penicillin drugs, but I want you to be familiar with these, at least have a reference here in your PowerPoint, because when you get out to the clinical world, you'll need to know all of the generic names and trade names for the epidemiologist or the infectious disease doctor. So some of the generic names for the penicillin drugs would be methicillin and oxacillin. The trade name would be staphycillin and prostaflin, but you don't need to know the trade names for me. You just need to give me an example of a few of the generic names. So a few of the generic penicillin drugs would be methicillin and oxacillin, and also ampicillin and amoxicillin, okay? And then carbenicillin and ticaricillin, and piperacillin and azlocillin. These are derived to combat specifically staphylococcus infections. Penicillin codrugs would be things like augmentin, that's amoxicillin and clavulanic potassium, and then another penicillin codrug is timentin, which is ticaricillin and clavulanic potassium. So just be able to give me a few examples of the penicillin-derived drugs. Now, keep in mind there are some other drugs that can actually be antagonistic to the penicillin drugs. Erythromycin and chloramphenicol, as well as the tetracyclines, may actually inhibit the penicillin drugs. Neomycin can actually decrease the absorption of your penicillin drugs. So if you are on a penicillin drug, you do not want to use a topical drug like Neosporin. This brings us to the next class, which are the cephalosporins. These are structurally similar to penicillin drugs, but are more modifiable. These are the more advanced beta-lactam drugs, and they are grouped in generations. Our first and second generation cephalosporins are good for gram-positive infections, and our third and fourth generation cephalosporins are good for gram-negative infections. The cephalosporins are bactericidal. They inhibit the cell wall synthesis of the organism, and they are commonly used in the treatment of Staphylococcus, certain enterics like E. coli, Klebsiella, and Proteus. They can be used in the treatment of Haemophilus influenza, and they can also be used in some anaerobic infections like infections of Bacteroides. So the first generation cephalosporins are best used for treatment of gram-positive infections. They are very good for gram-positive infections except for Enterococcus and MRSA, but other than that, they're pretty good drugs for the gram-positive infections. Some of the generic names you want to be familiar with are cefazolin, cefalothin, and cefapirin. And again, the trade names are Ancef, Keflin, and Cefadol, but you don't need to know the trade names, and you only need to be able to give me a couple examples of the generic names. Our second generation cephalosporins are okay for gram-positive infections, but they're not as good for Staphylococcus infections, but they're also good for Moraxella infections. Some of the second generation cephalosporins would be cefmanidol and cefuroxime. The third generation cephalosporins are very good for treating multi-resistant gram-negative infections. Some of the generic names you'll want to be familiar with are cefotaxime, ceftazidime, and cefparazone. The fourth generation cephalosporins are good for gram-negative infections, but they're not good for ESBLs. And one such fourth generation cephalosporin that you want to be familiar with is cefepime. You may hear the term P-lactamase, although this is kind of an old school term. It refers to any enzyme that inactivates the cephalosporins. Bugs have the enzyme cephalosporinase. The carbapenems are the more refined beta-lactam drugs, and they are bactericidal. Drugs that I want to talk about in this slide are meropenem and imipenem, and they are effective because they inhibit cell wall synthesis of the organism. The carbapenems are commonly used in the treatment of enterics and gram-positive organisms. The carbapenems are a very good broad-spectrum drug, and they are also used for resistant enterics. They can also be used for the anaerobic infections. Okay, there are new forms of carbapenem resistance starting to develop, and that would be because of the new deli-metallo-beta-lactamase enzyme that render carbapenems useless. This enzyme has been isolated in Klebsiellas and E. coli as well. Now, there is a susceptibility test called the modified Hodge test that we can use to determine if our bug produces carbapenemase. If our bug produces carbapenemase, then that makes them resistant to the carbapenem drugs. Now, the way that we do this test is we make a lawn of E. coli 25922. Now, that's not the organism we're actually testing, but that is the quality control organism that we use to make our lawn. Then what we do is we put a meropenem disc right in the center of our plate, and then we take a sterilized loop and we make 4 lines of our organism that we're actually testing. If you get a clover leaf pattern like you can see denoted by the 1 in the image, it means that our organism is resistant to the carbapenem drugs. This brings us to the aminocyclitols and the aminoglycosides. We cannot use the aminoglycosides for anaerobes. They work, though, through an oxygen-dependent mechanism. So these are generally used for seriously ill or hospitalized patients. The aminoglycosides and the aminocyclitols are bactericidal, and they are bactericidal because they interfere with protein synthesis. They actually disrupt bacterial ribosomal protein levels. They are used commonly in the treatment of Enterococcus, Pseudomonads, and Enterics. But this is a drug that needs to have peak and trough values monitored to avoid toxicity. We want to make sure to see that the maximum bacterial activity is being achieved without promoting toxicity to any part of the body. Now again, the aminoglycosides cannot be used for anaerobes, okay? You're probably familiar with some of the aminoglycosides. Some of the generic names would be streptomycin and gentamicin, amikacin, kanamycin, spectinomycin, and tobramycin. Streptomycin and gentamicin can be used together, and we use them together synergistically. We will actually do streptomycin and gentamicin synergy screens on our microdilution plates. We can see this on the microscan panels. High doses of streptomycin and gentamicin may be synergistic to one another, or we can add streptomycin and gentamicin to increase the effects of penicillin. There's only one ansomycin drug that I'm going to talk about today, and that's rifampin. This is the only drug we're going to talk about in this group, and it is bactericidal. It inhibits DNA RNA polymerase in bacterial cells and is commonly used in the treatment of MRSA, Neisseria meningitidis, and Mycobacterium. Mycobacterium, of course, is the genus for Mycobacterium tuberculosis. Okay. One thing that's interesting about rifampin when you take it is that it will actually turn your urine red. It can actually turn your saliva and tears red as well. Now, rifampin is a really good drug for MRSA, but you got to be careful because it is very toxic on the liver. The next class I want to talk about are the macrolides, and the macrolides are actually a good antibiotic choice for people that are allergic to penicillin. The macrolides would include things like erythromycin. Okay, these drugs are bacteriostatic. They inhibit protein synthesis, and they're commonly used in the treatment of gram-positive infections, and then a gram-negative infection would be Haemophilus influenza. Some generic names for the macrolides would be erythromycin and azithromycin. Erythromycin is a very good drug of choice to use for gram-positive infections. We cannot use clindamycin for anaerobes, but clindamycin is actually in a drug class called the glycosanamides, which are similar to the macrolides. They are particularly useful in the treatment of MRSA, protozoan infections, and also anaerobic infections. It's been linked to causing outbreaks of Clostridioides difficile, however. Clostridium is the old name, but the new name is Clostridioides difficile. Some Staphylococcus appear to be sensitive to clindamycin and resistant to erythromycin. The D test will determine if the staph is actually inducibly resistant to clindamycin. If the D test is positive, clindamycin cannot be used. This is a test to determine inducible clindamycin resistance to Staphylococcus species. How we set up this test is we make a lawn of our Staphylococcus. We put an erythromycin disc and a clindamycin disc 15 millimeters apart from one another on the plate. We incubate the plate, and if you see a D-shaped zone, it indicates clindamycin resistance. And you can see that in the image on the right. It looks like a capital D. The next class of antibiotic are the glycopeptides, and these glycopeptides are bactericidal. They interfere with the formation of bacterial cell walls, and they are commonly used in the treatment of MRSA, coag-negative staph that are very resistant. Some of our coag-negative staphs can be pretty resistant, and you can use it to treat endocarditis associated with Streptococcus viridans. Vancomycin is the only glycopeptide that we're going to talk about. IV vancomycin is sometimes used for treating MRSA when nothing else works. The quinolones and the fluoroquinolones are a class of antibiotics that we're going to talk about next. These drugs cannot be used in kids that are under 18 years old because it is too hard on their kidneys. The quinolones and the fluoroquinolones are bactericidal. They inhibit DNA activity, and they're commonly used in the treatment of the gram-negative infections. You probably remember ciprofloxacin and levaquin being used during the 2001 anthrax outbreaks. So some of the generic names for the quinolones and fluoroquinolones are ciprofloxacin, moxifloxacin, linezolid, and also levaquin. Okay? The use of these drugs are counterindicated in children under 18 because it's super toxic to their kidneys. Another drug I want to talk about that is specific for treating gram-negative urinary tract infections is called furidantin. That's also known as nitrofurantoin. It is the drug of choice for urinary tract infections with enterics. The sulfonamides are another class of antibiotics that are bacteriostatic. They inhibit the essential metabolites like folinic acid. It works well to use sulfonamides to treat urinary tract infections because you can get a high concentration of this drug attained in the urine. It's very effective against E. coli and Proteus mirabilis, which are the #1 and #2 cause of urinary tract infections. Patients have to have their urine alkalinized to avoid sulfur crystals forming in the renal system. Sulfur crystals can actually cause damage to the kidneys, actually specifically the nephrons of the kidney. And you'll talk more about the anatomy of the kidney when you get to chemistry and you start talking about urinalysis and the sulfa drugs. There's only one drug that I want you to remember, and it might be easier in this case to memorize the trade name. The trade name for this drug is called Bactrim, and I'm okay with you memorizing that. The generic name is sulfamethoxazole trimethoprim. It is sometimes used synergistically with something else for MRSA. This brings us to the tetracyclines and the phenocols. Okay, tetracycline and chloramphenicol are both bacteriostatic and they both inhibit protein synthesis. Tetracycline is a really good broad-spectrum drug. However, you don't want to use it in kids under the age of 18 because their bones are still developing and it can actually turn their teeth brown. Chloramphenicol is a really good antibiotic to use for salmonella, but most of the time salmonella in adults is self-limiting and we don't treat that with antibiotics. However, in cases of people that are immunosuppressed or kids under the age of 18, if they have a case of salmonella, the doctor may prescribe chloramphenicol. We just want to avoid putting our host into a carrier state. And then finally, I know you've been waiting for it, the last classification of drugs that I want to talk about are the polypeptides. And that would include things like bacitracin and neosporin, colistin, and polymyxin B. These are bactericidals. These drugs affect cell wall permeability and alter the osmotic pressure of the cell. They're good drugs for gram-negative rods and also for gram-positive organisms. So that's it. We've talked about all the different drug classes. We've talked a little bit about antibiotic history, a little bit about rules of host defenses, and adequate antimicrobial therapy. If you have any questions, please reach out.